So it's been such a privilege to hear all my Leadership College classmates present on their amazing projects. So thank you to all of you folks. I'm going to talk about my project, which is Team C equals Cure, implementing hepatitis C treatment in the primary care office. So I think leadership often begins just right in your own backyard. And within a system, if you're not one of the administrators, it can be hard to implement change. So that was my goal, to address a real problem that was facing our clinic for a number of years, which was access to hepatitis C treatment for our own patients. Next slide. So I'm going to give you a little context about our clinic, just to have some background. So my clinic is Western North Carolina Community Health Services. We were founded in 1994, received Orion White for HIV funding and HRSA funding in 1995, and we got our FQHC designation in 2007. We do have adult and pediatric medicine, outpatient OB, medication-assisted treatment with buprenorphine, dental care, integrated behavioral health, lab, pharmacy, patient assistance, and care coordination already as part of our clinic. Right now, we're a little short-staffed, but we have 15 medical providers, 7 physicians, 2 PAs, 6 nurse practitioners. We serve about 16,000 patients, and of those, about 760 are living with HIV, and 500 identify as transgender. So for those two populations, we serve an 18-county service area of Western North Carolina. And we identified, as part of this project, about 350 active patients with hepatitis C. Next slide. So hepatitis C carries a huge disease burden in the US. It's estimated that about 2.4 million adults are living with hep C, and only about 40% of those are aware, only about 60% are aware of their infection, 40% are unaware. It's the leading cause of death from liver disease and the leading cause of liver transplantation in the US. And sadly, the rate of new hep C infections is increasing. So you can see from the graph between 2009 and 2018, that rate of new infections is really increasing, particularly in the age groups from 20 to 29 and 30 to 39, that's primarily driven by the opioid epidemic and the use of injection drugs. Next slide. And just to put things in kind of a local context, North Carolina is kind of in the middle range of new hep C infections. Next slide. So the CDC has updated the recommendations for screening, and they're a lot easier now. Every adult should be screened at least once. Every pregnant person should be screened every pregnancy, and anyone with risk factors should be screened regularly. But when you're doing this screening, what are you going to do if somebody gets a diagnosis of hep C? It's really important to be able to offer that treatment to patients where they live. Next slide. So in 2011, we really saw a game changer in medicine, and it's not that often that big game changers come along. So this was really, really exciting for me, especially as an HIV provider. The new class was the direct acting antivirals, and this really changed the environment for hep C treatment. These medications are 95% effective, and 95% of people can actually be cured with an 8 to 12 week course of treatment, as opposed to months and months with a really low success rate that was prior to the development of these drugs. Next slide. The World Health Organization actually has a goal for the elimination of hep C, and that includes reduction in hep C related mortality by 65% and reduction of new infections by 80% by the year 2030. And towards that end, the American Association for the Study of Liver Diseases has suggested strategies which include the integration of hep C treatment into primary care settings, but that's been kind of fairly slow to be taken up by primary care providers. Next slide. So in terms of my project, the goal was, first of all, to identify how many patients have hep C in our population. And that wasn't as easy as it sounds. The problem list data was not very clean. There were a lot of patients who carried the diagnosis of hep C in their problem list, but they either cleared the infection in the past or they'd been treated in the past. So each PCP had to go through and kind of clean their own data so we could get some real numbers. We really wanted to be able to provide this treatment right with the patient's own PCP, not to have a siloed program or a pull-out clinic, but to let each PCP kind of be empowered to treat their own patients. We wanted to kind of identify some of the barriers before we rolled it out to the whole clinic. So to that end, we formed a committee and we identified 4 or 5 test patients to kind of do some trial and error and see how it went. So the patients were chosen by their payer source. So uninsured, which we have a very high percentage of uninsured in our clinic, Medicaid, Medicare, and also HMAP or PCAP, which is the AIDS Drug Assistance Program. Next slide. So we recognized that we were going to need a whole team. And like I said, we wanted our team to have all the primary care providers. We wanted to utilize the clinical pharmacists, and they were actually so excited to be able to join this project and increase their face-to-face patient time, which is a goal that they had on their agenda for a long time. We have amazing patient assistance specialists who already were quite experienced working with med assistance programs. The medical assistants were super important because they're the ones who really do the prior authorizations. And then the pod nurses are the ones that usually have the contact with patients by phone. So we made a committee of kind of a representative from each of these groups, including an administrator, and we met over about a 6-month period. We met 3 or 4 times as we treated our kind of pilot test patients. So after about 6 months, we felt ready to launch this with the whole clinic. So we scheduled a 1-hour training with all the primary care providers. Next slide. Let me just go back a minute and mention some of the barriers we identified with the team. So the prior authorization, as always, is sticky and a little bit messy and not fun and paperwork oriented, and it changes with time. So that was one of our biggest barriers. We recognized that we didn't have a place to store medications when they were mailed from the pharmaceutical companies, waiting for the patient to come in and initiate and pick up the meds. So we identified a locked cabinet that we could use for that. The pharmacist came up with a space to do the patient counseling and a script to use to kind of standardize the counseling for patients. And we needed to be able to follow up patients and order the refills in a timely manner so there wouldn't be a gap in their treatment, and also to be able to track current and treated patients. So next slide. So at the training for the PCPs, we tried to make it fun. I came up with these algorithms, which are pretty easy. It might look complicated, but it's actually pretty straightforward to help walk people through the steps of treating one of their patients with Hep C. And I got some help from my college-aged daughter with graphic design here, also for the logo for the project. Next slide. And we had all the PCPs download some apps on their phones, which are a great way to use technology. So there's some great apps for staging of hepatitis C fibrosis and scoring and risk of cirrhosis, and also a wonderful app for drug-drug interactions with the hepatitis C drugs. So in the training, we rolled out these algorithms. We had a case study and a test case. So we had every single PCP kind of walking through the test case and practicing how they would choose a medication for this patient, how they would run the drug-drug interactions. And it was sort of at the end, everyone felt super empowered and successful, like they were ready to go ahead and start treating their patients for Hep C. Next slide. The main resource we are using in our clinic is the hcpguidelines.org website, which really has a wealth of information in terms of treatment options. Next slide. So lessons learned, it's really important to assemble a good team of folks that are motivated and enthusiastic, and also to obtain buy-in from the administration. So I was very fortunate to have the support of our administrators. You need to keep that momentum going. And when you set a timeline, try to keep to it. Even if you're a little bit off schedule, it's important to kind of keep driving. And that sometimes means nudging people to get another meeting scheduled, nudging people on their action items. We tried to make it fun and include everyone. Plan for sustainability, especially things like staff turnover, which we really experienced during our project, and keep that knowledge moving forward. and then celebrate successes. So next slide. So as of now, we've treated 4 patients, which were kind of 4 of the test patients. And then we have, those people have achieved a 12-week SVR cure. And we have 15 patients in active treatment by almost all of the primary care providers. And I would say all the primary care providers have patients in process who are going to get started with treatment. So we've got this bulletin board and we're trying to mark our successes so that kind of everybody can see how many people we've treated. So thanks to everybody, and I want to especially thank Aubrey for being really good at giving those nudges and tolerating my frequent and last-minute changes of slides. Thank you.